Hello everyone. Today we are going to discuss about vitamin D that we know as a fat soluble vitamin. Vitamin D is also known as a cholecalciferol, calcitriol, anti-rachitic factor, as well as it is also known as a sunshine vitamin because it uh, develops or synthesizes on our skin on exposure to sunlight. Let's start with the chemistry. Vitamin D is known as a steroid hormone. We will say at the end why it is also known as steroid hormone because derived from the cholesterol. There are two different forms of vitamin D. One is ergocalciferol, that is vitamin D2 derived from ergosterol, that is found in the plant. Second one is cholecalciferol, that is also known as vitamin D3 derived from the 7-dehydrocholesterol, that is an intermediate of cholesterol metabolism and found in the skin. If we talk about the structural characteristics of vitamin D, it is very specific, having one hydroxyl group at carbon number 3, having two conjugated double bonds between C5 and C6 and between C7 and C8, and a long carbohydrate chain at carbon number 17. So this is a structural characteristics of vitamin D. Now we talk about the sources. The first and foremost important source is on exposure to sunlight. Sunlight itself is not a source, but on exposure to sunlight, this vitamin D is synthesized in our skin. If we talk about the food sources, then cheese, egg, particularly the egg yolk, the fish, salmon fish, there are the good sources of vitamin D, while the milk and yogurt, they are the moderate sources of vitamin D. Synthesis and activation of vitamin D. As I told you, the vitamin D, that is cholecalciferol, is synthesized in Malpighian layer of skin on exposure to sunlight. Now, when sunlight, particularly the UV light with a wavelength of 290 to 315 nanometer, fall on the Malpighian layer of skin that contains 7-dehydrocholesterol, get converted to cholecalciferol. This cholecalciferol is an inactive form of vitamin D, or what we can say provitamin. The same way, whatever food we are taking in the diet, that as a source of vitamin D, like fish oil, meat, egg, or milk, or any other dairy products, they are absorbed along with the fat because it's a fat soluble vitamin and reach to the liver. So the dietary fat as the dietary cholecalciferol as well as the cholecalciferol that is developed on exposure to sunlight in skin will transport it to the liver. In liver, there is an enzyme that is 25-hydroxylase enzyme that will add a hydroxyl group on the cholecalciferol, and it makes 25-hydroxycholecalciferol or calcidiol. Diol means two hydroxyl group. One hydroxyl group is already present on the carbon number 3, and the second hydroxyl group is added on the carbon number 25. This 25-hydroxylase enzyme, it requires magnesium and ADPase and molecular oxygen to carry out its action with the help of cytochrome P450. Now once this 25-hydroxycholecalciferol is synthesized, then it is transported to the kidney for further reaction, or what we can say further activation. In the kidney we have enzyme that is 1-alpha-hydroxylase, that will, as according to name, it will add one hydroxyl group at carbon number 1. So it becomes 1,25-dihydroxycholecalciferol. And there are 3 hydroxyl group, that's why it is known as calcitriol. And for this reaction, this 1-alpha hydroxylase required magnesium NADPH molecular oxygen, and along with that it also required ferredoxin reductase, and as well as cytochrome P450. So the production of vitamin D, that is directly proportional to the exposure of sunlight and inversely proportional to the pigmentation of skin. So those who have a highly pigmented skin or the dark skin, that produces small amount of vitamin D. So here the cholecalciferol synthesized in the skin, or what we are taking in the diet, it is a provitamin, it is an inactive form. It converted to 25 hydroxycholecalciferol, that is in the liver, that is a storage form of vitamin D, and it activated as calcitriol or 125 dihydroxycholecalciferol in kidney, that is the active form of vitamin D. Now let's go through the mode of action of vitamin D, how it acts. So it acts like a steroid hormone. The vitamin D entered inside the cell or the target cell. Then it binds with the cytoplasmic receptor. Our hormone, or what we can say a vitamin D, binds with the cytoplasmic receptor. Then it will internalize to get entry inside the nucleus. This hormone receptor complex binds with the Z finger of DNA, and it causes de-repression, resulting in transcription of that particular gene, and it synthesizes a protein, and that protein carried out its action depending upon the target cell. So this is the mode of action. So vitamin D act like a steroid hormone bound to the receptor. This hormone receptor complex get entry inside the nucleus. It binds with the or react with this DNA. It causes de-repression and helps in the transcription of particular gene, and after that gene is transcribed, it synthesizes a protein, and protein carried out its function. Now we'll go to the biological role of vitamin D. So vitamin D maintain particularly the normal plasma level of calcium and phosphorus by acting on intestine, kidney, and bone. So this is the role of vitamin D to maintain or to regularize the level of calcium and phosphorus in plasma. We'll see one by one its effect on intestine, kidney, and bone. Now action of this vitamin D, or the active form of vitamin D, that is calcitriol on intestine. The main role of calcitriol is to increase plasma level of calcium and phosphorus, and it is done by increasing the synthesis of particular protein, that is calcium binding protein calbindin. As we have seen in the mode of action, when it binds with the DNA, it causes de-repression and increase the transcription of gene, that is gene for calbindin protein. And this calbindin protein helps in the absorption of calcium, as well as it also increases the absorption of phosphorus from the intestine. Calcitriol also lowers the pH to facilitate the absorption of calcium and phosphorus. So it is the role of calcitriol on intestine. Now we'll see the action of calcitriol on bone. Calcitriol has a both anabolic as well as catabolic effect on the bone. It mainly acts on three types of cells of bone, that is osteoblast, osteoclast, and the osteocytes. It usually causes remodeling of bone. For that, sometimes it promotes the mineralization of bone if it is needed, or it also stimulates the mobilization of calcium and phosphorus from the bone. So that is called remodeling effect of calcitriol on bone. So whenever it is needed calcification, so it causes mineralization of bone, and we required more calcium in the plasma, that causes mobilization of calcium, or we can say demineralization of bone. So the calcitriol also increases the production of bone matrix protein like collagen and all, and hence it is also helpful in the increasing the density of bone. Now it's the action on the kidney. The calcitriol increases the reabsorption of calcium and phosphorus from the kidney and hence decreases the excretion of calcium and phosphorus. So we can say after going through the action of calcitriol on intestine, bone and kidney, ultimately it increases the blood calcium and the phosphorus level. Also the regulation. Calcitriol level is maintained by the feedback mechanism mainly, and it is also regulated by serum calcium level, serum phosphorus level, level of PTH, that is parathyroid hormone, as well as by the level of calcitriol itself as by feedback mechanism. We'll see how. You can see here when there is a calcium level decreases or the increased phosphorus level, it causes stimulation of parathyroid gland to releases the PTH. PTH act on the kidney and it stimulate the activation of vitamin D. It causes 1-alpha hydroxylation of calcidiol and forms a calcitriol. That calcitriol act on the gut, or we can say intestine. It promotes the calcium and phosphorus absorption, resulting in the increased calcium and phosphorus level. It also acts on the kidney, increase the calcium reabsorption. This is all due to the PTH, but when the calcitriol is increases, it also promotes the reabsorption of phosphorus also. And in the bone, whenever calcium level is down, it causes bone resorption and causes release of calcium and phosphorus. So there is increased level of calcium and phosphorus. So it's like this: when plasma calcium level falls, it increases the PTH, parathyroid hormone secretion. It increases the 125 dihydroxycholecalciferol level by increasing the hydroxylase activity in the kidney. This active calcitriol increases the intestinal absorption of calcium, causes demineralization of bone, and also increases the reabsorption of calcium from the renal tubules, and ultimately it increases the plasma calcium level. So this is the way how regulated calcium level is regulated by the calcitriol, and the calcitriol itself also regulated by this feedback mechanism. RDA, that is recommended daily allowance of vitamin D. For the children, it is about 400 international units per day. In adult, it is 200 international units per day. It's lower compared to children, or the children require more vitamin D because they have a growing age. So there is a growing bone required more calcium, and hence the more vitamin D is required. During pregnancy and lactation, vitamin D requirement is increased, and so it is about 400 international units per day. And above the age of 60, requirement increases to 600 international units per day. And sometimes unit is given in the RDA is given in the form of microgram, so you can convert by using this factor. 1 international unit is equal to 0.025 microgram. This is particularly for vitamin D. Now we talk about the level of vitamin D. What level of vitamin D is considered as a normal? So usually the vitamin D status that is measured, it is 25 hydroxycholecalciferol level. The normal level of vitamin D is more than 30 nanogram per ml of blood. When it is less than 30 but more than 21, so 21 to 29 is considered as a vitamin D insufficiency, that is early stage of vitamin D deficiency. And when it is less than 20, it considers a vitamin D deficiency, and when it is less than 10 nanogram per ml, it considers a severe vitamin D deficiency. The exact cutoff value for the deficiency and insufficiency still remain controversial, but vitamin D level less than 30 is considered as a somewhat insufficient or deficient level with vitamin D. We'll see the deficiency of vitamin D, why it occurs, go through the causes. So there are various causes, like first, inadequate sun exposure. As we have seen in the beginning, that vitamin D is synthesized on exposure to the sunlight or UV rays. So whenever we have inadequate sun exposure, that produces the deficiency of vitamin D, like using sunscreen with SPF 15 plus for a longer period of time. It blocks almost 99% vitamin D synthesis. Pigmented skin, aging older than the 65 years of age, winter season, or certain uh, like burqa and that kind of habit, it also reduces the sun exposure. Decreases the absorption when we take it in the diet. Because of certain reason it is not properly absorbed, like whenever there is a bowel bypass surgery, Crohn's disease that affect the intestine, so the absorption is affected, like in celiac disease also. Fat and cholesterol absorption inhibitor, if you are taking the drug that affect the fat and cholesterol absorption, so along with the fat and cholesterol, vitamin D absorption will also be inhibited or will be affected. Or inability to process the vitamin D. What vitamin D synthesized in our body or we are taking in the diet is called a calciferol, that is inactive form. It is activated by through two steps. One is in the liver, second is in the kidney. So whenever there is an impaired production of 25 hydroxycholecalciferol due to liver diseases or due to kidney diseases, there is an impaired production of calcitriol. So in that case, there is a chances of deficiency of vitamin D. In hypoparathyroidism or in X-linked hypophosphatemic rickets, there is a chances of development of vitamin D deficiency. There are other causes like prolonged breastfeeding to the children. Certain medications like steroid, barbiturates, phenytoin, rifampin, ketoconazole, they affect at different uh, ways of activation of vitamin D, as well as the target organ resistance due to vitamin D receptor mutation. So these are the causes of vitamin D deficiency. Now, if there is a deficiency of vitamin D, that leads to certain diseases. Now, what they are? So they are mainly rickets in children and osteomalacia, that is in adult. We'll see one by one. Rickets, that is usually seen in the children, along with the decreased serum calcium level, mainly due to insufficient mineralization of bone, and bone become soft, pliable, and easily get fractured, along with certain bone deformities. Also, there is a delayed dentition in the children suffering from the rickets. So these are the clinical features of rickets usually seen in the children suffering from vitamin D deficiency, like delayed closure of fontanelles. As we know, at the time of birth the fontanelles are open and over a period of time it get closes, but in vitamin D deficiency or there is a rickets, the closure is delayed. There is a bowing of frontal bone, dental hypoplasia, or as I told you, there is a delayed dentition. There is a pectus carinatum, in which there is a or what we can say pigeon chest, in which anterior posterior diameter of chest is increased compared to the side by side. There is a swelling in the wrist and ankle joint. There is open wide sutures in the skull. Craniotabes can also feel, that is a thinning or softening of the skull bone in the children. There is a rachitic rosary, in which there is a prominent beaded appearance at the costochondral junction is joint due to inflammation. There is a Harrison sulcus, the groove seen at the lower end of the rib cage, and that is corresponding to the costal insertion of diaphragm. So we can feel a very deep groove at the lower end of the rib cage, along with the bowing of legs, that is due to gravitational force as well as due to muscle pull. So these are the classical features of rickets. A clinical feature, along with the biochemical changes occurs in the ricket, that is decreased level of vitamin D3, that is 25 hydroxy cholecalciferol level, increased alkaline phosphatase because it affects the bone, along with the hypophosphatemia and hypocalcemia. There are different types of rickets seen in the children. What we have discussed is the classical rickets due to vitamin D deficiency, and that can be treated by giving vitamin D supplementation. Second type of ricket is hypophosphatemic rickets, that is due to defective renal reabsorption of phosphate. So it is mainly due to defect in the phosphate reabsorption at a kidney level. For the treatment, we can give vitamin D supplementation along with the phosphate. It is very important. Vitamin D resistant rickets, that is seen in the Fanconi's syndrome. For that, there are gene or stem cell therapies is undergoing still. Not confirmed or sure for that. Renal rickets, that is why due to disease of kidney, so the vitamin D is not activated. In that case, we have to give vitamin D, the active form of vitamin D from the outside, that is calcitriol. The another type of ricket is due to end organ refractoriness to calcitriol. That because due to decrease in the number of receptors, or the cytoplasmic receptors are there but abnormal, so the end organ effect will not be there to calcitriol, and this can be treated by giving a mega dose of vitamin D. Now the second disorder seen due to vitamin D deficiency is osteomalacia, that is seen in the adult, and it is also known as a adult rickets. So the osteomalacia, that is osteo and males, that is a Greek word, and the literal meaning of this osteomalacia is softening of bone. It is also seen along with the decreased serum calcium level due to mainly insufficient mineralization. Here you can see this is a compact bone, here there is a hollow or the porous bone due to insufficient mineralization. There is increased osteoporosis, bone become very weak, soft and pliable, and the most commonly affected bones are of spine, pelvis and of lower extremities. Osteomalacia patient usually manifest with the bone pain, severe malaise, the proximal muscle weakness and with the waddling gait. And the radiologically we can see a pseudo fracture. You can see here there is a pseudo fracture, or what we can say loser's zone of decalcification along with the course of major arteries. Biochemical changes, there is a decreased serum calcium phosphorus level, decreased vitamin D, that is 25 hydroxy cholecalciferol, and increased level of alkaline phosphatase and as well as parathyroid hormone. There are certain measures we can take to prevent vitamin D deficiency, and so we can prevent the disease like rickets and osteomalacia. For that, the most simple thing is sensible sun exposure. 5 to 30 minutes of sun exposure on arms and legs between 10 a.m. to 3 p.m. twice a week is sufficient or inadequate. According to American Academy of Pediatrics, that if we give infant and child around 400 units per day as a supplement or in the diet, we can prevent the ricket. All pregnant and lactated mother should take 400 international unit vitamin D supplementation daily during the pregnancy, even after the lactating period. The another way to prevent vitamin D deficiency is by the fortification of routine food products with vitamin D, such as like milk, butter, chapati flour, maida, cereals, etc. Then we go through the hypervitaminosis D. This is when the serum concentration is more than 150 nanogram per ml, and it usually seen when there is an excessive consumption of vitamin D. Overexposure of sunlight never produces the hypervitaminosis D, remember. The symptoms of hypervitaminosis D is usually because of higher serum calcium level, that is weakness, difficulty in speaking, polyuria, intense thirst, loss of appetite, weight loss, hypertension and joint pain. And over a period of time, due to this hypercalcemia, it leads to metastatic calcification, that is also known as calcinosis. Okay, so at the end, as I told you in the beginning, that vitamin D is also considered as a hormone. So vitamin D is considered as a prohormone and calcitriol as a hormone. So why? Because structurally both have cyclopentanoperhydrophenanthrin steroid ring. Vitamin D, that is cholecalciferol, is synthesized in the human skin by UV irradiation from its precursor, that is 7-dehydrocholesterol. Vitamin D is synthesized in skin, that is usually it's normally inactive and is a storage form, and it is activated to calcitriol by liver and kidney. The formation of the active compound, that is calcitriol, is under the feedback inhibition like the hormones. Like the hormones, it is produced in one organ and act on other or distant target organs for its activity. So it's a characteristics of hormone. Calcitriol act through the nuclear action, like the steroid hormones, they act through the nuclear action. And calcitriol maintain the calcium level or maintain the calcium homeostasis along with the PTH and calcitonin. Based on this, we can say this calcitriol is considered as a hormone, and vitamin D, that is cholecalciferol, is an inactive form of calcitriol, so that is known as prohormone. So this is all about vitamin D. I hope all of you understand vitamin D, its deficiency, its sources, and RDA. So thank you so much again. For more updates, kindly follow us on Insta account, that is @biochemistry4student. And if you like the lecture, so please subscribe, share, and like our channel.